since the traditional histology of polyps may not be so interesting for you, I changed the title a little bit into what is relevant in PT1 carcinomas in such polyps to allow you the distinction between, or to find the therapeutic decision between endoscopic treatment and colorectal surgery. So lots of these things I'm going to report you right now depend on your prior knowledge, depend on the pathologist's knowledge and your position in the whole system, so to say. And this is a table that shows you the frequency of certain polyps and the risk for transformation, for malignant transformation in the future. And the most interesting thing at the moment are probably the group of the sessile serrated adenomas, because in the literature it's still considered that the frequency is around 10, 11, 12, 13, 14, 15%. But in fact, in our recent series, it tends to drop. So probably the real frequency is less than 5%. And it's not clear why this is the case. So we have to see when the new publications come out how high the frequency really is. If you have a polyp, an adenoma with a malignant transformation into a PT1 colorectal carcinoma, this can be still a wide indication for endoscopic therapy, as you may all know, especially if just the upper third of the submucosal layer, the so-called SM1 layer, is involved, then the risk of lymph node metastasis is between 1 and 3%. And depending on your local morbidity and lethality on colorectal surgery, that is the trigger to decide for endoscopic therapy or colorectal surgery. And since the pathologists like to, or since you as the therapist need some markers to carry out the risk stratification, your pathologist can give you a wide variety of different markers to assess this risk more clearly. So first, it's definitely the depth of invasion, and that should be measured in microns. I will come back on that later, because in a polypectomy specimen, you never know how deep the submucosa has been attached to that specimen, because that is only possible in colorectal surgical specimens. The resection status, so is the lesion taken out laterally completely, is it out basally completely, and the tumor grading. The grading is a bit complicated. In most publications, the grading drops out in the multivariate analysis, and that's because the grading is not carried out in a proper way. It's carried out in many other organs very, very appropriately, especially the breast, the uterus, the prostate, but definitely, interestingly, not in the GI tract yet. So there is something we have to work on as pathologists. Lymphatic invasion, well, that's a risk factor for lymph node metastasis. Venous invasion, it's a risk factor for hematogenous metastasis, for example, to the liver. But not so much for lymph node metastasis. But we know if patients have venous invasion, they have a tendency to have lymphatic vessel permeation and positive lymph nodes as well. So, and the next more promising thing is the tumor cell dissociation or budding of the tumor cells on the front of the invasion, depicting the aggressiveness of the tumor growing against its surroundings, and perineural invasion. Perineural invasion is mostly something you find in PT2 tumors, but very, very, very rare in PT1 tumors. So this is something you should not expect in the early carcinomas. So, and when we receive a polypectomy specimen in pathology, we have many ways and many possibilities to cut that specimen to get the most representative sections, as you can see here. And that is mainly different. It has something to do with the size of the lesion and with the shape of the lesion, and also of the experience of the pathologist, because we should avoid any tangential cuts. If I would cut the head of this polyp off, I probably cannot evaluate the basal margin anymore. So this has something to do with the experience of the pathologist. So first, a pathologist has to this is the diagnostic scheme I do on normal. First, we make a diagnosis, what type of lesion we are dealing with, the depth of infiltration, most important, and then other risk factors, and then we assess the resection lines. The horizontal line, the lateral margin, we call HM, and that can be 0 for tumor-free, or it can be a 1 for positive with tumor. And there will be the European guidelines coming out soon, and adding a small c or d to that information. C means cancer is at the resection line. D means dysplasia is in the resection line. So you always know whether there is some cancer left or whether it's just some dysplasia of the margin, at the margin or the edge of the lesion. Same is true for the vertical, the deep margin. Also a little c or a d will be added soon. When we assess the depth of infiltration, as I already told you, it's only possible to do the pragmatic subdivision into upper, lower, and middle, a third of the submucosal layer when you have a colorectal surgery specimen. In polypectomy specimens, you should measure as a pathologist. And unfortunately, there are worldwide many different approaches, how many microns the upper third of the submucosal layer resembles, and but the most frequently used is 1,000 microns. So that's in most guidelines, and that is because the nodal involvement in lesions less than 1,000 microns deep is very low. It looks different in pedunculated lesions, as you can see here. For pedunculated lesions with a stalk, you should add the Haggett's classification, because the stalk is always the upper submucosal, the upper third of the submucosal layer, and that means it's a low risk situation per se. But as you can see, when it goes down to level 3, if the stalk is heavily involved in the tumor, the frequency of nodal involvements go up. But the initial publication, as you can see here, by Roger Haggett, did not include so many cases. But it's a good start for pedunculated lesions. So ask your pathologist in pedunculated lesions for the Haggett level to make the proper decision. The grading, as I already said, is a bit difficult to assess. There are different ways worldwide used to assess this, and in results, these publications are often not comparable anymore. So there has to be done something on this. What's very reasonable is the proposal of the American pathologists. They say if you have more than 50% of the glands, then it's probably low-grade lesion. If you have less, then it's a high-grade lesion. But now somebody could ask, what's about with exactly 50%? It's not possible to assess anything that is exactly 50%. So, but in general, this is quite fine working for routine diagnosis. This is a publication from Japan with a little bit different way to assess this, and it turned out that the grading is an independent predictor. But this is very rare in the literature, so to say. Lymphatic vessel permeations can be easily detected by antibodies, but it makes it also very cost intensive if you use a lot of antibodies. So this is always a bit problematic, and it turned out that the blood vessel involvement in these publications were not an independent predictor. So, and it turned also out that we have to use special stains, not immunohistochemistry, just histochemistry. It's lots cheaper to assess blood vessel involvement. And then it becomes really significant. So this is something we probably have to do on a regular basis, and this has been proven several times. If the lymphatic vessel permeation is reassessed by an expert in detecting such lesions, then it becomes very, very significant for the progression-free survival, for the cancer-specific survival, and is also a very valuable information for the further prognosis of your patient. This is a table that I have taken from one of the publications we wrote for the European guidelines. Lots of publications, lots of very, very difficult to understand classifications, how to assess budding at the front of the invasion of the tumor. In fact, there is one very recent publication from Ireland, and that is they just did it like it's present or it's absent. And that works very, very well. So your pathologist should stick to a very, very easy to assess method. And this is probably the easiest thing to do. It's irrelevant how many single tumor cells are there per square, millimeter or micrometer or whatsoever. And it's irrelevant how much they do proliferate. It's irrelevant how much necrosis is there whatsoever, or fibrosis. Doesn't play a role, just present or absent, full stop, period. Perineural invasion, as I said, it's only relevant in deeper infiltrating tumors, T2, as you can see in the first line. So, in conclusion, the role of the pathologist is to make the primary diagnosis of the polyp or the tumor if there's has undergone a malignant transformation, and we need the special informations for you in endoscopic resection specimens or submucosal dissection specimens, about the complete resection, about the margins, and we need to assess and give you all these risk factors to leave also future options open for other treatment options. But on the other hand, the H&E is still the gold standard, and that is very easy to perform. And if in doubt, you should ask your pathologist for a second opinion and make sure that he or she is not going to the next room, but sends it outside. It needs to be sent outside. There is no doubt. And in the end, this is the diagram that you probably would end up with, that the pathology report gives you a lot of information to trigger the therapy versus into surgery versus endoscopy, and for the best outcome of your patient. And the lower half of the picture of the slide shows you what the pathologist has to take into account to achieve this and to help you making this decision. Thank you very much.
Thank you, Dr. Vieth, for this excellent presentation and the important information you give us in order to decide about the future treatment of our patients. And I would like to ask you, how easy is to give us this information in every patient during the daily routine work?
We do a lot of consults, and so the best predictor is the quality and the experience of the pathologist. If the specimen is properly embedded, then it's very, very easy. If it's not properly embedded, for what reason ever, then you're in big trouble, and you will not recognize it till next week or tomorrow. Your patients, if you do the wrong decision, your patients will come back within 2, 3, 4, 5 years and may ruin the reputation of your whole institution if this is not working properly. So ask your pathologist, if you have the slightest doubt that there's something strange with the reports, that some lesions are too often or too less diagnosed, ask your pathologist. And you need to do this. I observe it so many times, I see it so many times that the surgeons or gastroenterologists do not ask and force their pathologists to put the right things into the report. Or the quality of the embedding is so low that you hardly can make a diagnosis on this. So this is what you have to make sure. For the whole infrastructure, you need to perform this. It's not only the endoscope, it's not only your skills to take out these lesions. You have to make sure that the whole infrastructure is fitting into your plans.
What percentage of the specimens are in good condition in order to have a complete report?
if you talk about the condition, it's two things. It's the experience of the endoscopist or the surgeon who took it out. If somebody starts with these methods in the very first beginning, the specimens look very, very bad. There's a lot of blood congestion. The surface epithelium is taken off. There are cautery artifacts that really, and the lesions are often not very deep. There's not a broad band of submucosal tissue attached, so they're too thin, so to say. And these are problems in the beginning. If you get more experience as an endoscopist, this becomes more easier. The second point is the quality by the pathologist. We have seen from our consults that there are institutions, they deliver constantly a very bad job. But if both are experienced, there's 100%, almost 100% chance to get a complete and very excellent diagnosis on both sides.
Thank you. Any more questions from the floor? Yes.
Can I ask Michael, not infrequently now, we take a patient to laparoscopic theatre and we'll attempt endoscopic resection for a big or a complex polyp, particularly on the right side. And we may successfully remove that polyp endoscopically, but there's still doubt about whether there could be early invasive cancer. And for the patient, it's a disaster if we take it out, we stop the procedure, and then they've got to come back for an operation. How easy is it for you to do urgent histology on a specimen that's been removed with the patient under anaesthetic in theatre? We need an answer. What do we do? Is it okay, or does the patient need a right hemi?
I agree. I don't like. And if it's really a minute cancer with just one gland popping down into the submucosal layer, the pathologist will probably destroy the specimen during the frozen section, and will probably, there is a great chance, not to find this single gland popping down, because we cannot embed the whole specimen. We can slice it and see whether there's any suspicion, any gross suspicion for invasive cancer. So, but I absolutely agree that a frozen section would be absolutely preferable for these patients. So if you need these informations, we have to carry it out, but we don't like. And we would always, I would personally give you the information, okay, I will do it, but there's a chance that I will probably miss or destroy the specimen to a degree that we will not get a proper answer. But I would do, if you would ask me or urge me to do this, I would do it, but I would give you the limitations also.
Thank you.
Okay.
Just one more question. Excellent presentation. Thank you very much, Dr. Vieth. I just want to take you beyond the histology, and I want also the panel just to give us their expertise opinions. When we do have a submucosal invasion, how easy for the endoscopist to assess that endoscopically? To my knowledge, there is. I know it's really tough question to address, but it's a common practice.
Dr. Saito is sitting at the other end of the table as the...
To my knowledge, there is one from Kikuchi, which tried to correlate the lifting status property of the lesion with the submucosal invasion.
Yeah.
Are there anything new that we should...
Please, Dr. Saito, correct me, but it's the little depressions you have in such lesions. They depict a higher risk for that. The non-lifting sign, but that are probably more advanced lesions. If you have these minute infiltrations, I personally see that it can be problematic. But Dr. Saito, please confirm or.
Would you mind please comment, please? Can you just give us a comment, Professor Saito?
Yeah, so I have some slides in my presentation. I will explain.
Okay. Professor Saunders, about this lifting status and the endoscopic assessment of the submucosal invasion.
I mean, it's not a histopathological question, is it? But I mean, we have a number of classifications. We have the NICE classification using MBI, types 1, 2, and 3, looking at colour, vessel pattern, and the overall surface pattern of the lesion. But the single most important thing I always find is just simple Paris classification. If the lesion has obvious ulceration, or there's deformity or expansion of the fold, or it doesn't lift, it's not endoscopically resectable. So most of the time it's a fairly obvious call.
Any more questions or comments from the floor? Okay. If not, thank you very much again for the excellent presentation.